If you've ever felt judged for considering a weight loss medication, or quietly wondered whether needing one means you've failed somehow, I want to spend the next few minutes explaining what these medications actually do, not the social media version, the facts. Because there's a lot of noise around this topic, strong opinions from people who have never sat across from a patient who has tried, genuinely, repeatedly tried, for years. And there's also a lot of confusion about what these medications are, how they work, and what the evidence actually shows. So let's do this properly. Before we talk more about medications, we need to talk about the hormone. GLP-1 stands for glucagon-like peptide 1. It is not a drug. It is a hormone your gut has been producing your entire life. After you eat, specialized cells in the lining of your small intestine release GLP-1 into the bloodstream. It then does several things simultaneously. It signals the pancreas to release insulin in response to rising glucose. It acts on the brain to reduce appetite and increase the sense of fullness. It slows the rate at which food leaves the stomach, also known as slowed gastric emptying, which prolongs the feeling of satiety. And it suppresses glucagon, a hormone that would otherwise tell the liver to release more sugar into the bloodstream. GIP, glucose-dependent insulinotropic polypeptide, formerly known as gastric inhibitory polypeptide, is a related incretin hormone released earlier in the digestive process. For years, it was considered a minor player in weight regulation. More recent research has revised that view significantly, as we'll get to. Now here is the evolutionary piece, and it's worth pausing on. GLP signaling is ancient. This gut-brain hormonal feedback system predates modern humans by hundreds of millions of years. It evolved to regulate food intake based on what was actually available, which, for most of that history, was not much. Meals were infrequent, caloric density was low, and the gut had time to communicate with the brain before the next eating opportunity arrived. Modern processed food is engineered to move through that system much faster than the feedback can keep up. It's hyperpalatable, calorie-dense, and digested quickly, which means the satiety signal arrives late, quietly, and often too politely to compete with what the food industry spent billions designing. Semaglutide is the molecule. The brand name depends on the dose and the indication. Ozempic is lower dose semaglutide, approved for type 2 diabetes. Wegovy is higher dose semaglutide, approved specifically for chronic weight management. They work the same way, but the dose and the indication differ. In trials, participants on semaglutide 2.4 mg lost an average of around 15% body weight over 68 weeks. For context, prior to this class, 5 to 10% was considered a clinically meaningful result. 15 was a different conversation altogether. Mechanistically, semaglutide does three things that matter for weight. First, it acts directly on appetite centers in the hypothalamus, the brain's hunger regulator, reducing the drive to eat. Second, it slows gastric emptying, so food sits in the stomach longer, stretching stomach wall receptors that signal fullness to the brain. Third, it reduces what researchers call food reward, the dopamine-driven pull towards highly palatable food. Patients often describe this as the food noise going quiet. For people who have experienced constant preoccupation with food for most of their lives, this shift in food noise is often described as life-changing. One patient put it to me this way: before starting medication, they would regularly find themselves thinking about the tub of ice cream sitting in the freezer, wondering when it was time for that sweet treat. After starting the medication, they realized one day that they had forgotten it was even there. Side effects are predominantly gastrointestinal, things like nausea, vomiting, constipation, mostly during dose escalation, and typically improving over time for most people. There is a boxed warning for thyroid C-cell tumors based on rodent studies, but anyone with a personal or family history of medullary thyroid cancer or MEN2 syndrome should not take this class, out of an abundance of caution. One other finding worth highlighting: semaglutide has been shown to reduce major cardiovascular events, meaning heart attacks and strokes, by 20% in people with existing cardiovascular disease, independent of diabetes status and overall weight loss. In other words, those with existing heart disease can actually lower their risk of heart attack and stroke even if they don't lose weight or have diabetes. A weight loss medication with demonstrated cardiovascular benefit is a meaningful development in the medical world, and we will come back to that. Tirzepatide, also known as Mounjaro for diabetes or Zepbound for weight management, takes the approach one step further. It's a dual agonist. It activates both the GLP-1 receptor and the GIP receptor simultaneously. GIP, as mentioned earlier, was long considered a secondary player. The updated understanding is that activating both receptors together actually appears to produce additive effects on appetite suppression, fat metabolism, and insulin sensitivity that exceed what either receptor produces alone. In trials, Tirzepatide produced average weight loss of around 20 to 21% at the highest dose, with some participants exceeding 25%. The medical world has never seen these kinds of numbers from weight loss medications until now. The side effect profile is similar to Semaglutide, predominantly GI during dose escalation, improving thereafter. In practice, individual response varies, of course. Some patients do better on one than the other, and the science doesn't yet fully explain why. What is clear is that Tirzepatide has a higher average ceiling for weight loss. Weight loss alone explains only part of what these medications appear to do. On the cardiovascular side, a large randomized controlled trial of over 17,000 participants showed semaglutide reduced the risk of major adverse cardiovascular events by 20% in people with obesity and pre-existing cardiovascular disease who did not have diabetes. This is a cardiovascular outcome trial, not a weight loss trial. The implication is that the benefit extends beyond what the scale reflects. On the kidney side, semaglutide reduced the risk of serious kidney disease progression by 24% in people with type 2 diabetes and chronic kidney disease. Renal protection from a weight and metabolic medication was not something the field anticipated at that magnitude. On the liver side, in people with metabolic dysfunction-associated steatohepatitis, also known as MASH, which is the more severe inflammatory stage of fatty liver, semaglutide has shown meaningful improvements in liver fat, MASH resolution rates, and in some cases early fibrosis. If you've watched the fatty liver videos in this series, you already know why that matters. These are not minor findings. They suggest that GLP-1 and dual GIP-GLP-1 therapies are doing something metabolically meaningful beyond simply reducing food intake. One of the most common concerns circulating about these medications is muscle loss, and this is worth addressing carefully because the framing online is often misleading in both directions. First, the accurate part. Yes, these medications are associated with some lean muscle mass loss alongside fat loss. This is real and documented in clinical trials. Now, the context that usually gets left out. Every significant weight loss intervention, dietary restriction, bariatric surgery, or medication, anything involving a calorie deficit diet, with or without medication, results in some loss of lean muscle mass alongside fat. This is not unique to GLP-1 therapies. It is a predictable physiological consequence of any meaningful caloric deficit. The body, as it becomes smaller, requires less structural support and less muscle to move itself. Across major clinical trials, roughly 25 to 40% of total weight lost on these medications is lean muscle mass, with fat accounting for the majority of it. And critically, because fat loss predominates, the overall ratio of lean mass to fat mass in the body actually does improve. Most patients end up with a better body composition than they started with, even accounting for the lean muscle mass loss. Now, the more important nuance. The people losing the most muscle on these medications appear to be the ones doing the least to preserve it. A large real-world analysis of over 670,000 GLP-1 users found that reduced exercise tolerance was the strongest predictor of greater lean muscle mass loss, more predictive than the drug itself or the dosage. The mechanism isn't complicated. Resistance training signals the body to preserve muscle tissue during a deficit. Without that signal, the body has less reason to hold on to it. Adequate protein intake matters for the same reason. These medications reduce appetite significantly, which is the point, but a meaningful reduction in protein intake alongside that calorie reduction accelerates lean muscle mass loss as well. So it means that it's even more important to make sure the calories you're consuming are good quality. So the honest framing is this. Lean muscle mass loss on these medications is largely modifiable. It's not an inevitable or inherent side effect of the drug itself. It's a consequence of a calorie deficit that resistance training and adequate protein can substantially attenuate. There's a recurring and ominous social media narrative that goes something like this. Nobody tells you that these medications cause gastroparesis. And I think it's worth spending 60 seconds on what the evidence actually shows, because the reality is more nuanced than these posts suggest. Gastroparesis is a condition where the stomach empties abnormally slowly, causing nausea, bloating, vomiting, and early fullness. GLP-1 medications do slow gastric emptying as part of their mechanism. That's intentional and therapeutic. For most people, this contributes to satiety without causing a clinical problem. True gastroparesis requiring medical attention is not common with these medications in otherwise healthy individuals. The picture becomes more complicated in a specific population. People with long-standing type 2 diabetes who already have autonomic neuropathy, which is nerve damage from years of poorly controlled blood sugar that impairs the nerve signals controlling stomach motility. These patients already face elevated baseline risk of gastroparesis independent of any medication. Adding a drug that further slows gastric emptying can, in some cases, tip a borderline system into symptomatic territory. The thing is, this isn't a hidden danger. It's a known risk factor that should inform prescribing decisions, and it underlines why these medications work best when initiated and monitored by a clinician who knows the patient's full history. The nuance here matters. It's a real consideration in the right clinical context, but it's not the widespread undisclosed catastrophe that some posts would have you believe. You better believe the pharmaceutical industry is actively researching new weight loss medications as we speak. Orforglipron was FDA approved in April 2026. It's the first oral, small molecule GLP-1 receptor agonist that can be taken without food or water restrictions. Retatrutide is a triple agonist, GLP-1, GIP, and glucagon, currently in late phase 3 trials. It showed around 24% weight loss by 48 weeks. Ongoing studies are also looking at whether this medication can help to reduce chronic knee pain from osteoarthritis. CagriSema combines semaglutide with cagrilintide, an amylin analog that targets a separate satiety pathway. An FDA filing was submitted in late 2025. The pattern isn't subtle. Each generation is targeting more hormonal pathways simultaneously, and outcomes are approaching territory previously seen only with bariatric surgery. The long-term safety data will take time to accumulate, but the trajectory of medication development so far is significant. These medications didn't come out of nowhere. They are the product of decades of research into hormones that your body was already using to regulate hunger and metabolism. What changed is that we finally learned how to work with these systems more precisely and at a scale the body couldn't achieve on its own in a modern food environment. Whether a medication is appropriate for any given person is a clinical conversation worth having, one that depends on individual history, metabolic context, and goals. But the science behind how they work is worth understanding, regardless of where you land on that question. The earlier videos in this series on insulin resistance, hunger hormones, and weight loss physiology provide the foundation for a lot of what we cover today. Links are in the description. If you found this video helpful, consider subscribing. I post videos regularly focused on evidence-based explanations of metabolic health and beyond, without fear, blame, or oversimplification. I'm the Science MD, and this is the science behind your health. Thanks for joining, and see you next time.